related to the procedure and technique. And the slide speaks for itself. I'd like to start off actually with a case study, which then brings me into sort of more recent indications for poem. And this was one of our first cases referred to us about 7 or 8 years ago now. And she was a 36-year-old lady who originally presented with really severe chest pain and dysphagia. And her original barium swallow in 2013 showed quite a marked delay in emptying. And then subsequently she had an endoscopy, which didn't show a dilated esophagus, didn't look particularly abnormal, but there was significant resistance at the OGJ. You can see in the bottom right how tight it was. And if you have a look at the barium swallow, the esophagus itself looks fine, but you can see this typical bird's beak at the bottom. So she had manometry, and this is very much in keeping with type 2, although we had thought that she may have type 3 given the severity of her chest pain. Anyway, she initially underwent a laparoscopic alismaltamine fundoplication, which helped the dysphagia but didn't have a huge impact on the pain, and she was waking almost every night at one point. So she subsequently went on to have a Botox injection through 2013 and several in 2014, and they really addressed the pain well, and she was symptom-free for 2 or 3 months, and then her symptoms came back. So we repeated the manometry, and although there was absent peristalsis, as one would expect with achalasia, but the IRP, the integrated relaxation pressure, which is a pressure differential between the chest and the abdomen, was normal. And it's one of the major criteria for achalasia according to the Chicago classification. But you can see there's a second bar on swallows. And we thought perhaps this is where the pain and the recurrent dysphagia is coming from. Anyway, keep that in mind through the lecture, and I'll just take you through a brief history of achalasia and the development of poem, and then we'll come to some cases. So this is a normal manometric study. You can see there's a peristaltic wave, and on initiation of the swallow, the bar at the bottom relaxes, and this is normal esophageal function. But with achalasia, which is split into the 3 different types, 1, 2, and 3, you don't get this propagated contraction. The type 3 in the bottom right, you can kind of see what appears to be a slight propagation, but it's not. It's just a very high pressure zone. But what you can see, what's common to all these, is you don't get relaxation of the high pressure LOS. Type 2 is typically characterized by esophageal pressurization because there's still residual tone, whereas type 1, you've got a big baggy esophagus and you can't really measure any pressure at all. And you can see the barium swallows, you've got to be careful with type 2. Often the barium swallow looks entirely normal, whereas type 1, it's hard to miss. You get this big dilated esophagus with lots of residual food. And type 3, the barium swallow can look like anything, but endoscopically you get these kind of lumen obliterating spastic contractions, and sometimes they almost hold the scope. You can't pull the scope out. Incredibly powerful with very, very high pressures. So very briefly, current treatment for achalasia is nicely divided into medical, mechanical, and for end-stage disease, we've got a huge sigmoid esophagus. Some of these patients need an esophagectomy. Medical therapy, nitrates, calcium channel blockers don't really provide more than a 20% improvement in symptoms. So these are really a bridge while you're waiting for a defined treatment. Botox can be very effective, but it's short-lived. And what I don't like about it is we've seen cases where the submucosal plane has been completely obliterated by fibrosis. And then the mechanical techniques are the classic Hellers with or without fundoplication, poem, and balloon dilatation. And I'll come to this a little bit later. The balloon dilatation, to be effective, has to be serial balloon dilatation. So you start with 30, 35 after 1 to 2 weeks, and consider 40 if necessary. 40 has a much higher perforation rate. So on to the poem. So poem was first described, or at least an endoscopic approach to myotomy, back in 1980 with Ortega. And it wasn't until 2007 that Pazrika first described the feasibility of using the submucosal space to undertake an endoscopic myotomy in 2007. And he used a porcine animal model. And then Inoue was the first to describe POEM in 17 patients with a really astounding initial success rate in those 17. And since then, now there have been numerous publications with variations from age from 3 to 93. And also there's been an extension of the indications from achalasia to other major motility disorders. So a brief review of technology with POEM. Well, you've seen Speedboat with Rohan's lecture. Essentially, you need a knife, you need submucosal fluid, you need an endocap, and we all use the Fuji conical cap, a full GA, and CO2 insufflation. I'll come to CO2 in a little bit later, but that's all you need. You don't need to spend a lot of money to set up. The major cost, of course, is the general anaesthetic. So the technique. There are 4 reasonably simple steps. The first being the mucosal incision, which is traditionally at the 3 o'clock position. I'll come to that again. And that is extended 13 centimetres from above the GOJ to 3 centimetres distal to the OGJ. I'm sorry, the step 2, the submucosal tunnel. So usually the mucosal incision is around 2 centimetres, and that allows easy access. You can reduce it to about 1.5 centimetres, and that enables you to retain more CO2 within the tunnel rather than whistling out. But then there's always a risk of that pressure zone extending into the peritoneum and the thorax. So you have to be a little bit careful if you've got a very tight mucosal incision. Anyway, back to the tunnel, you extend that through to the OGJ and then into the stomach by about 3 centimetres. Now, the myotomy starts between 3 and 4 centimetres distal to the mucosal incision and then extends through the LOS into the stomach by about 2 centimetres. I put 3 here, but 2 to 3 is usually fine. And then once you finish the myotomy, you come out and close the mucosal incision. Reasonably straightforward, and I put here start with our nub. And as you saw, Rohan very nicely put the initial clip at the very distal end of the incision or just beyond it. So you created a nice nub in order to close the mucosal breach. And if you've got a perforation through any complication endoscopy, you should always create the nub first, and that makes the rest of the closure really easy. Now, the first step, the mucosal incision, reasonably straightforward. Make sure when you do your initial submucosal injection, you're in the submucosal space so you don't cut deeper into the muscle. And then this is the patient slightly skewed around. So this is an anterior approach. And then once you're in, you can start the submucosal tunnel. Now, there are a variety of knives here. You can see the triangular knife. We saw last year Rohan used the Speedboat, but you can use virtually any knife. My preference is the Irby water jets. It's just very, very quick. And always try to keep the muscle on the bottom of the plane and the mucosa on the top, and cut as close to the muscle as you can, which then reduces the likelihood of mucosal breach. And diathermy all vessels as you go through to ensure a nice, clean, dry plane. Now, you can see here the mucosal, the circular muscle on the right. I try to preserve the longitudinal muscle, not because that improves your outcome and reduces the likelihood of a big baggy esophagus, but it's really nice to see a direction. So if you cut perpendicularly to the circular muscle, you know you're going in the right direction. I mean, it also keeps you out of the mediastinum and peritoneum. If you've got your preserved longitudinal muscle, then it keeps a slight barrier. But if you do cut through the longitudinal, it really doesn't make any difference at all. So the myotomy, as I've said, begins 3 centimetres distal to the mucosal incision. And usually start tentatively and open up a few of the circular muscle fibres until you can see the longitudinal, and always cut perpendicularly so you can cut in a straight line. And if you're not sure where you are, always come out of the tunnel, go back in, and make sure you follow the blue staining of the fluid to make sure you're in the right position. A couple of tips. Once you've got plenty of fluid within the stomach, you know you're definitely in the right place. As you reach the LOS, you can see the palisade vessels, and they change very abruptly. You can see these fine reticular vessels in the submucosal plane, and you know you've reached the LOS at that point, or at least the OGJ. And continue your myotomy through the LOS to at least 2 centimetres beyond the bottom of the OGJ. Now you can see there, as you've cut through, on the top right, you can see the myotomy has been undertaken. You can see a nice margin of the cut circular muscle layers, and you can't actually see the longitudinal muscles here. As you splay, they just simply fall apart. Now, clipping the mucosa, as I've said, you can see here, make a nice nub, and then it comes together very, very nicely. And use as many clips as you need to. I tend to use the Cook Instinct clips because they're very easy to use, and you can reopen them. So if you're not in the right place, you can then reclose them. Now, in contrast to laparoscopic Heller's myotomy, POEM can be performed on any side of the esophagus. An anterior myotomy or lesser curvature myotomy is performed between 12 and 3 o'clock. This is with the patient on their back in the supine position. And this was the first approach implemented, and this is the approach that Noe first used. Now, the advantage of this is you preserve the posterior sling fibres alongside the angulus of his. And the theory is that you reduce the amount of gastroesophageal reflux by partly preserving the anti-reflux barrier within the diaphragm. Now, the posterior myotomy is between 5 and 7 o'clock in the supine position, and has since been introduced, and some people like to use that more frequently than the anterior. It kind of makes a slightly easier myotomy, owing to the perpendicular axis of the knife on the circular muscle, so it's very easy to cut the circular muscle through the LOS and into the stomach. So one randomized control study, small study, showed that there is no significant difference between the anterior and posterior POEM approach with regard to efficacy in terms of symptomatic outcome, and safety seem to be the same. Although some researchers have shown there's a slightly higher incidence of mucosal injuries in the anterior myotomy group, and possibly slightly less gastroesophageal reflux. And you can see this picture here. This is 3 months after the myotomy. You can see the clips fall off, but you do end up with these little nodules. So does POEM work? What evidence do we have so far? Well, early on, the early analysis since Inoe's first publication have really shown that POEM works as effectively of all the other approaches. And you can see here, this was a large meta-analysis of over 500 patients. And the pooled analysis showed a success rate as defined by an Eckhart score of less than 3. And just in case just to remind you, Eckhart scores a composite score of dysphagia, regurgitation, chest pain, and weight loss. And 3 defines a really good symptomatic response. So this is what we generally use as a marker of success. And if you look at all the other studies, initial success rate of around 90%, 85 to 90% is pretty common. So the earliest studies showed a pretty good outcome. Does it last? Do any of these last? We know that there's drop-off with pneumatic balloon dilatation or Heller's, and the studies have shown up to 60 months that there is retained success, a small drop-off, but POEM lasts. And here you can see a large retrospective trial of over 80 patients with combined European and US experience, showing a drop-off at 2 years. You can see in the graph top left, with a retained 21% success rate at 2 years. So how does POEM compare to Heller's myotomy or pneumatic balloon dilatation? What do we say to our patients when they come and see us in clinic? You know, say, which is better? What would you suggest, doc? And you have to give them the information so they can at least make their own mind up. So there are a lot of early comparative studies, Bayani, Chan, showing that there was reasonable comparity. But these were comparative studies. These were low quality cohort studies looking at different groups. But there seemed to be similarity across the board. And in a large systematic review that came out 3 years ago with a meta-analysis looking at POEM versus laparoscopic Heller's myotomy, the dysphagia scores both at 1 and 2 years were the same. Now, when it comes to the first high-quality study, which was published 2 years ago, undertaken by Werner, multi-unit study, the outcomes were pretty similar. The Hellers, all of the Hellers had a partial or dorsal underplication, and the primary endpoint again was the success of POEM defined by the improved Eckhart score of less than 3 or 3 or less. There's a non-inferiority margin of 12.5% in the primary analysis. Now, the 2-year follow-up showed that 83% of patients that you can see here in the POEM group had clinical success and 81.7% in the Hellers group. Now, interestingly, there was an increase in, not significant, in serious adverse events in the Hellers group over POEM, and there was a slight increase in reflux in the POEM group. But this is really important. So when you look at the reflux group, you've got to remember that at least 30 to 40% of patients after any treatment for achalasia, and even before, have evidence of gastroesophageal reflux. When you look at this study, the only excess of reflux was in those with LA grade A reflux esophagitis, which is really very minor, and all these patients respond to PPIs. But when you look at the ambulatory pH scores in these patients with ambulatory pH studies, they're exactly the same. So as you can see here, the drop-off from 3 months to 24 months. Now, on to POEM versus balloon dilatation. This was the first randomized controlled study, again, published in 2019. The one point about this study is a lot of the old studies comparing balloon dilatation with another modality just compared either a single balloon dilatation rather than serial balloon dilatation. We know the outcomes of serial balloon dilatation are much higher. So they did a 30 and a 35, and there was a slightly better success rate with in the POEM group, with declining durability in the balloon dilatation group. In terms of the symptom scores, however, there's no difference in the integrated relaxation pressure, the IRP, as measured on high-resolution manometry, or the Barham height. And there was a greater incidence of reflux in the POEM group than the dilatation group, and that was significant. The difference was 47%. So we can say to our patients, yes, you can have serial balloon dilatation, may not be quite as good as POEM, but you have less reflux. Now, is POEM safe? What is the safety data we have to date? And in fact, we've got some really good safety data suggesting that it is as safe or safer than either Hellers or balloon dilatation. In a very large retrospective analysis of over 1,500 patients over a 5-year period, the initial complication rate was about 3.3%. And this included delayed mucosal barrier failure, basically the mucosal kits coming apart, or the mucosa falling apart, usually at the site of the LOS. Delayed bleeding, sometimes in the tunnel, and that can be addressed by going back in, reopening the tunnel and diatherming the bleeding, hydrofluorax and pneumothorax. Now, interestingly, multivariate regression analysis demonstrated that an institutional experience of less than a year, air insufflation rather than CO2 insufflation, and mucosal edema were identified as independent risk factors for complications, which is really interesting. So if you do an endoscopy and you notice that the mucosa looks really unhealthy, maybe you shouldn't do a POEM at that time and bring them back. Interestingly, in the group, when they introduced CO2 insufflation, the adverse incident rate declined from 3.5% to 1.9%. So the ESG recommends that we should only be using CO2 for POEM. We know this. You should only be using CO2 for any therapeutics. And if you do get any gas-related effects with CO2, then just stop, because it's reabsorbed so quickly. So if you get a lot of surgical emphysema, for example, with bruising, just stop and wait and eventually subside. And the same with the big pneumoperitoneum. Stop what you're doing, leave it for 10, 20 minutes, and it subsides. If you really want to, if you can see that there's some compromise of the diaphragmatic movement, you can just put a large bore cannula in and deflate the gas. It doesn't take long. So, when compared to HELAs, the adverse incident rates appear to be very similar. So, to come to a conclusion, what new updates do we have? So, there's an interesting randomized control study comparing a short with a long myotomy. And the short myotomy was just less than 3 centimetres and the long myotomy was 8 centimetres. And they looked at a number of different outcomes, including reflux, Eckhart scores, Barham column, IRP, and operative time. And the only real difference was, not surprisingly, it's a lot shorter to do a short POEM. In fact, nearly half the time. So, lovely piece of work suggesting that we don't need to extend the myotomy as long as the original 8 centimetres. And now, personally, in my unit, we've now adopted a short myotomy, and so far we haven't seen anecdotally any change in outcomes. So have the indications for POEM changed? Well, again, for jackhammer esophagus and other major motility disorders, although it is being used, the data isn't really there yet. But for type 3 achalasia, there's an original study showing that the outcomes for POEM versus other modalities were better for POEM. But this is quite an old study now. But more recently, there has been a retrospective analysis of 36 patients looking at POEM for type 3 achalasia. A lot of these parents had other modalities such as Botox, pneumatic balloon dilatation, and HELAs with poor outcomes. So a lot of these were redos where the outcomes are typically poorer. But you can see the Eckhart scores were excellent, from 7 to 0. IRP went down from 25 to 4.5, and the Barham column length went to 0. So this really does show that doing extended myotomy in these patients with type 3 achalasia really is beneficial. And I would advise that you really scrutinise the HRM to make sure you can define exactly how high to undertake the myotomy to make sure you've got the right level, sometimes for the cervical esophagus. So to finish off, back to our case, this lady had this bar of high pressure about 3 to 4 centimetres above the LOS and was experiencing, if you remember, really severe chest pain both spontaneously and after food. So this was a manometry, and you can see this bar. So we ran it through our physiology MDT, and the decision was to undertake an extended myotomy up to this bar. And that's exactly what we did in March 2015. And her symptoms almost completely resolved. She had mild chest discomfort, but very rarely, was never woken. And interestingly, only had some mild reflux, which was completely controlled on ad hoc PPI. She did have a bit of niggling discomfort, and you can see bottom right, she had a retained clip, which we removed after 5 months, and then this sort of niggling discomfort disappeared. So in conclusion, what do we know about POEM? So we know that the short and long-term outcomes, both in cohort studies and now randomized controlled trials, are at least as good as the other modalities, serial balloon dilatation or laparoscopic helizomyotomy. And it seems to be safe or safer than the other modalities. Reflux, well, POEM doesn't cause intractable reflux, and it very much depends what you're measuring. But if you look at LA grade A, it does seem to be higher in POEM than laparoscopic helizomyotomy, and certainly with balloon dilatation. But none of our patients, and as far as I can see in the literature, no patients with reflux have needed anti-reflux surgery, and all these patients respond well to PPIs. And what's new? Well, looks like short myotomy may be the way to go, particularly in patients with type 1 and type 2 achalasia, particularly type 1, where you want to do a short myotomy because of the angulation of the esophagus. And the operating time is shorter, and that may lead to fewer complications, even though they're rare. And POEM gives us another therapeutic option. So these should all be displayed to our patients when we see them in clinic. So I'd like to thank you very much and now come to a few poll questions. So the first one is, which of the following predict treatment failure after treatment with achalasia? A, pre-existing chest pain. B, height of column. C, esophageal width greater than 4 centimetres, or all of the above.
We are just waiting a bit for people to finish